Hi, my name is Julia Henderson-Kalb, and I'm talking to you today about feeding difficulties with older adults and what we might be able to do about that. Before we get started, though, I do want to mention that this presentation, as well as others that you might have been watching, have been part of a grant that St. Louis University has. And you can read through this disclosure, but it's just part of that grant, and we want you to be aware of that. So today, the main things that I want to discuss with you are these following objectives. I would like for at the end of this presentation for you to be able to understand why it is important to consider feeding difficulties with individuals, to consider what affects people's ability to feed themselves, and then how you might be able to help individuals you work with to feed themselves, or how you can most effectively feed them if they do need that help. So I want to kind of just start off with a discussion of why should we care about this? What difference does it make? And the overall answer to that is that when people eat less, they end up losing weight. And, when you're younger and some people want to lose weight, that's a perfectly acceptable thing. But when we do eat less, we do lose that weight. And for older adults, a lot of times it's not recommended that they lose weight per se, for a variety of reasons. For adults who are 65 or older, losing weight can really cause issues with muscle loss rather than fat loss. And once you lose muscle mass, then individuals can become weaker. And weakness causes all kinds of issues with falls or poor quality of life. And decreasing oral intake, decreasing the amount of food that's going into your body, can decrease the appropriate nutrition that a person is getting. And that, decreased nutrition can cause issues with poor wound healing, especially with pressure sores, if the person is too weak to move. And all of these different situations, all of these concerns can lead to an increased risk of hospitalization, either admissions or readmissions, as well as death. And so we certainly want to be concerned with what an older adult is putting into their mouths and the nutrition that they're receiving. So, again, why should we care? The first thing that I want to consider is that self-feeding affects the social and psychological status of a person. If you think about that, every person wants to be independent. So if you imagine the emotional toll it takes of no longer being able to feed yourself, or making a mess of things when you are feeding yourselves and dropping food or spilling drink, uh, feelings of embarrassment or humiliation or depression can be natural when suddenly they lose control of that. So for us, verbal prompting or encouraging a patient or social interaction with others can really significantly improve many individuals' ability to consume their own food and fluid. The only time that this might not be true is if someone is cognitively aware of what they're able to do, but not physically able to feed themselves without spilling or making a mess. In which case, that feeling of embarrassment with feeding, they may not want to be around others. So that socialization piece is a give or take sometimes. But generally speaking, these are good rules to consider when trying to encourage people to feed for themselves. So, what is causing a person's difficulty with feeding can influence what can be done about their difficulty with feeding. So, it's important to kind of consider what is the cause, what's causing the problem. Is it an injury? Is it something that is temporary, like a shoulder or an elbow or a hand fracture, or some sort of injury that's just going to be causing them problems for a little bit? And then do they really care whether or not they're getting some help? Or is it something like a traumatic brain injury or a spinal cord injury that might be a longer process to improve upon, but still improvements can be made, and independence can maybe be in the future for them with feeding. Or is it something that is an illness or a health diagnosis, such as a flu or a heart attack that causes fatigue and decreased strength? And then, will that get better or will it remain the same? Or chronic diseases such as rheumatoid arthritis or osteoarthritis can affect fine motor coordination, how well they can grip those utensils when they're trying to get the food to their mouths. Um, or things like congenital abnormalities or developmental disabilities. As people age with diagnoses like Down syndrome or cerebral palsy, they might have difficulty with how well they can even sit up straight, how stable their trunk is, how well they can coordinate that fine motor coordination, as well as cognitive concerns. So just being aware of maybe what is causing it can maybe make a difference in, is this long term? Is it a short term situation? What needs to be done to help with the problem? But not only do we want to consider what the diagnosis is or what their difficulty is, what's causing it, we also just want to consider the person as a whole, and how those diagnoses or might be affecting them physically, cognitively, socially, culturally. These are all things to be kind of considering when we are looking at what's causing a feeding difficulty and what we can do about it. So, kind of starting off, we're going to focus on the physical issues first. And the first physical issue that I wanted to discuss with you is positioning. So you will see a lot, I'm sure you've seen a lot in your careers, that a lot of people aren't sitting up straight as they're trying to feed themselves. They're not sitting up straight most of the day sometimes. This can be caused by habit. If I ask you right now to check how you're sitting, you might be slouching a little bit. You might not be sitting perfectly upright at that 90 degree, 90 degree, 90 degree angle we like to be at, or what you can see on the picture in the middle, where, you're sitting upright and you're not leaning one way or the other. Um, but besides habit, it can also be because of that weakness or that fatigue that a person has. They might not have the core strength to sit upright, and which we have to worry about. We might be checking their positioning and trying to adjust it. Or they might have abnormal tone from some of those neuro diagnoses, like a stroke or a traumatic brain injury or cerebral palsy or things like that, which take a little bit more. It's not just saying, hey, why don't you try to sit up a little bit more straight or whatever you might need to do. There might need to be physical assistance in changing that positioning. So we want to figure out again what's causing the problem and what can be done. But sometimes it's just encouraging them to sit up straight. But when you're talking about positioning for feeding, you want to just consider what is the best position for feeding. Like I said, sitting straight, upright, in the center of a chair is the best thing to do. If we can get a patient out of a wheelchair and into a regular chair, that's going to be the most beneficial for them for feeding most of the time. Standard tables are anywhere from 28 to 30 inches tall, and dining room chairs are meant to be under dining room tables. Wheelchairs, if they are a normal height, they're a little higher in the seat. If they're at a hemi height or a lower height, they're much lower than the seat. So that changes where your body is when you are sitting trying to eat. And so that changes the positioning and where your arm has to reach, and all of these different aspects of it. So if a person can get into a dining room chair rather than sit in a wheelchair, that's usually encouraged. Um, if that can't occur, and if the table is either significantly higher or significantly lower, is there the ability to get a hospital table or one that can raise or lower so that it's at a more natural feeding position? Another thing that you want to consider when there are physical concerns is the idea of strength and endurance. Again, if you sit and you think about what all the little things that it entails for you to be able to feed yourself, you need to be able to grasp your hand close enough to be able to hold a utensil or a cup and sustain that grasp for an extended period of time. You need to be able to reach out with your shoulder to get the food. You need to be able to, use the muscles in your upper arm to bring the food to your mouth. You need to be able to turn your wrist and your forearm in a certain way to bring it from the plate and bring it up to the mouth. So all of these muscles have to work in the right order to be able to feed yourself. So that can be a problem. Once people get food into their mouth, they need to be able to keep their lips closed so it doesn't spill out. They need to be able to use their tongue to move it to the back of their mouth or not put it in either side of their cheek. And the swallowing reflex needs to be there as well. And besides that, they just need to be able to tolerate sitting up long enough to be able to eat. Trying to lay down or lay in bed and not be fully upright can cause problems with choking, can cause problems, with food going down the wrong pipe. So we want to make sure that they're able to tolerate sitting up in that full 90-degree position for long enough to be able to feed themselves. So, what can you, as a CNA, do about these issues? We're going to be talking about different ways that you can physically assist someone if that is what they need later on in this presentation. But you can physically help them get the food to their mouths, or you can physically feed them yourselves. Um, Ideally, we like it if someone can feed themselves. Number one, it's less work for you. And number two, people tend to eat more when they're able to feed themselves. So, what can you do in that regard to increase their ability to feed themselves? Well, a lot of times if they have finger foods versus having to use utensils, that can be really beneficial. Just being able to pick something up and put it in your mouth versus having to get it onto a spoon or a fork or a knife. I mean, cut it with a knife, and then get it to your mouth can make a big difference. So if finger foods are available, that's always a big plus. The easiest thing to do is to see if changing where the plate is in relation to the person is going to be the easiest way for you to do something without having to go back to the, dietary and ask for different food or physically assist the person. So, can you just move the plate closer to them on the table? And again, going back to that table height, would getting a hospital table to raise it up so maybe they can just keep their hand on the table and be able to move it that way. Um, or, changing, maybe being down lower in their wheelchair or up higher if you don't have that difference in table height, maybe changing the chair could help as well. But those are all different things that you can do as a CNA to help with trying to allow a patient to independently feed themselves. What else can be done for these concerns if you're working with a lot of people, you're trying to feed a lot of individuals at the same time within a certain amount of time that the food is out. Um, so it's difficult to think about all of these things all at once. But what you can do is if you start to notice that someone is regularly having a problem, um, talk to your nurse, talk to your occupational therapist or your physical therapist or your speech therapist in your building, because each one of us, I am an occupational therapist, each one of us can do different things to help with feeding. Um, OTs can work on strengthening with a person's grip or with their strength in their arms. We can work and bring lots of adaptive equipment to make the patient or work on their positioning so that they can more easily do their feeding themselves. Speech pathologists have all kinds of different, they use stimulation or other techniques to try to strengthen the muscles in the person's mouth, or can recommend different diets that might make it easier for the person to swallow and feed themselves. And physical therapists can work on endurance through strengthening and cardiovascular activities and all of these good things. So just bringing up a problem with any therapist, any nurse, to have that recommendation to, maybe an evaluation is in order can be really beneficial to the patients. And you're seeing them eat more often than anyone else. And so it's really important that if you see those, you start to see a decline, maybe one of us can help if the techniques that I'm talking about today aren't enough. So another physical limitation that you might see with feeding that can cause problems is vision. Um, if you know your patient has one of the different diagnoses that are on this list, these are pictures that kind of demonstrate what they might be seeing when they're trying to feed themselves. So, macular degeneration is the picture over on the far side at the top. Um, the central vision is lost. So, but not only that, these pictures are not perfect in how they demonstrate it, but also with macular degeneration, they can have sensitivity to light, or they might be losing some of their color vision. So they might not be able to see differences in food colors if they're really playing against the plate. Um, Usually they like bright lighting but they also can have a high sensitivity to ambient light. So what the lighting is in the room might make a difference. Um, Glaucoma is the loss of that side vision. So they've got kind of tunnel vision, as you can see in that picture. They can also have blurry vision or difficulty seeing in really dim light. Diabetic retinopathy, which is kind of the center picture on the bottom, is kind of blurry with spots. They can have floaters, they can have more vision loss, so that can be a problem. Cataracts is kind of that blurry, foggy vision. They have difficulty seeing in low light. There are glares or halos. And this last one over to the side, hemianopia is usually occurs with strokes. It can be other neural problems, but it's usually when someone's vision is split and one side of it's completely missing. Um, all of these, all of these difficulties can be concerning for eating, especially if they're really sensitive to bright lights or dim light, depending on the lighting in the cafeteria space. But I would say that macular degeneration, where they can't see in the center, or that hemianopia, where they can only see one side, that can be where people will just completely miss some of the food on their plate, which can certainly be a problem. So, what can you do for the vision issues? Um, First of all, just if a person if you're working with someone long term, trying to create a routine of where different things are on a plate can be helpful. So, if you have a divided plate and you always put the main dish, in the biggest space, and you always put their drink on their right side behind the plate, and you always put the utensils on the left side, and they can be aware and feel where those things are, or a regular plate. And again, just making sure that, center in the front is always the main dish, sides are, up to the right and left, and so on and so forth. But talking with the person, seeing what makes them feel safest with the positioning of the food, and have it like that each time the person eats. If there is an option to change the color of the plate with the food, like if your facility has bright plates and they have a lot of, mashed potatoes or chicken or something like that, having something that's a bright plate against those general, kind of beigeier color foods, or a white plate with brightly colored foods, but just trying to make sure there's somewhat of a contrast, because that contrast can really help with visual problems. Um, Giving them verbal reminders, as far as, especially again with that glaucoma, or I'm sorry, the macular degeneration, which is that spot in the middle, or the hemianopia, where they can only see one side, just saying, oh, make sure you look over to your left, or glance all around to make sure you're getting everything off your plate. Just giving them that verbal cue can sometimes help them to eat more. And then finally, reducing glare in the dining room is always a good idea. Um, Whether or not it's pulling down the shades in a dining room or painting the room a light color to increase reflection. But since you don't often have control of the physical space of the room, solutions can be either sitting an individual next to natural light if that's what they need. If they need more light, that natural light can be a benefit. Or if glare is a problem, encouraging the patient to wear sunglasses can also help. It seems weird to tell people to wear sunglasses inside, but it really can make a difference if that is a concern with them being able to see that glare. So we're going to move from the physical areas that we might encounter and kind of talk a little bit about cognition and how that can affect a person's ability to feed themselves. And this picture it's a little fuzzy, but I feel like it demonstrates kind of a vicious cycle of dementia or cognitive impairment. So, someone with a cognitive issue with dementia with Alzheimer's disease, um, because of that diagnosis, uh, there was a study that before I kind of move forward, I'm going to skip back just a little bit. There was one study that was found that on average, people with cognitive issues require a little over 3 times the amount of time getting assistance with feeding than people without cognitive issues. So if you spend 3 minutes helping someone who doesn't have a cognitive issue, you'll probably spend about 10 minutes helping someone with a cognitive issue. So that a lot of times taking more time to eat and having the confusion of what to eat or how much to eat or all the things that go into cognitive impairment can increase the amount of assistance that they need and also decrease how much they are intaking. And as we talked about at the beginning, decreased intake means that there's increased weight loss and increased nutritional deficits, which again causes problems like falls or wound healing or increased hospitalizations. And we all know that when someone with dementia falls or gets rehospitalized or has problems with wounds, that cognitive impairment can worsen. And then it just keeps going and going and going. So it can be a real problem for individuals with cognitive issues feeding. So again, what can you do? These are some different modifications that can be used for people with cognitive issues. Again, finger foods. I read an article, a study of 12 residents in a nursing facility who had experienced weight loss, and they were put on a diet consisting completely of finger foods that did not require any utensils. And after 6 months, 10 of the 12 residents had stopped losing weight, and all 12 of them had become more independent with their feeding skills. So I can't I can't emphasize enough that if finger foods are available, that's something that you could advocate for within your facility. Um, Reducing distractions can be a huge game changer for people with cognitive issues. We obviously want people with cognitive issues with dementia to have a lot of social interaction that can help them, having conversations, um, being involved in activities. All of that can be very helpful, um, generally speaking, with someone with cognitive issues. But when we are trying to get them to focus on a task like feeding, removing those social situations, removing any sort of distraction other than focusing on feeding can be very helpful. So either putting them at a table with less people or with people who are not very talkative and are just maintaining their own space can be beneficial. If there's an option to face an individual with a cognitive impairment towards a wall, so they're not seeing all the people walk by, they're not seeing people come and go and get up, that can be beneficial. Um, and just making sure that they are able to concentrate on that food. If there's the ability to only give them one type of food at a time, so maybe the main food the main meal at a time at first, and then moving on to a vegetable, and then moving on to a dessert, so that they don't have to make choices when they're sitting there as well. That can also be beneficial. Rote memory is another option for helping someone with cognitive impairments. And if you haven't heard of rote memory, that's this idea of learning something by doing it over and over and over again. Think like times tables when you were a kid. Um, but it's also when things become habitual, we can kind of tap into that for someone who has a cognitive issue. So if you think about if you put toothpaste on your toothbrush and you put the toothbrush under the water, or vice versa, however you brush your teeth, you are almost automatically bringing that toothbrush. Once the toothpaste and the water is on it, you are automatically bringing it up to your mouth. You don't even think about it. It just habitually happens. Um, that's something that I, as an occupational therapist, uses a lot with people with cognitive issues. I will start a process for them, and hopefully, by starting it, they're able to continue it. And so that can be directed to feeding. If you can help the person get food on their fork or on their spoon, or if you can help them pick it up, sometimes they will just automatically bring it to their mouth without even thinking about it. It's just an automatic response to doing what they've been doing for their entire lives. So that's something to consider as well. Can we tap into that rote memory to kind of help? Or just verbal cues saying, "Oh, don't, pick up your food. Don't take another bite of that dessert." Maybe demonstrating it for them. All of those different cues can kind of help tap into that memory. And the final piece to cognitive issues as well as physical issues would be the idea of assisted feeding. And we're going to kind of go into the different ways that you can assist someone with feeding. So these are the three major ways that people can be assisted in their feeding process. And each technique is described as where your hand is as the caregiver being placed. So you can kind of see it in the pictures. The hand of the caregiver is the one that has fingernail polish on it, and the hand of the individual needing help does not have fingernail polish on it, if that helps. And we're going to kind of go into each one of these. But with each one of these techniques, I can't emphasize enough, verbally talking your patient through using these techniques can be really helpful. Um, as an individual, you feed yourself every day and you don't think about it at all, but your brain, because it's your own hand doing it, your brain knows when the spoon is coming into your mouth. And that your brain also knows, because you've been doing it for years, how far you're putting that spoon into your own mouth. And your mouth knows when to close over it and when to let go, and how your hand's releasing. Your brain, it's a magical thing. It allows you to do this without any thought. When you are putting food into another person's mouth, when you're helping with that situation, especially when it's direct, and we'll talk more about it, but if they aren't the ones physically completing the task, their brains aren't quite in sync with yours. So you might put the spoon a little bit farther than they're used to in their mouth, or maybe not quite so far. They might not know, they might not put their mouth and close their mouth enough in the perfect amount of time for you to pull it out. So talking through what you're doing, saying, "All right, let's," kind of like what you do when you're working with when you're working with a toddler or a baby who's trying to learn how to feed. Okay, open your mouth. Let me put this in. All right, close your mouth around the spoon. Okay, we're going to pull it out now, and have that conversation as you're going through can really help their brains figure out what you're doing and how to react to it. So the hand over hand technique is usually used for someone who has required ability to grasp a utensil. So they can hold on to a utensil, but they might not be able to get it to their mouth. So those fingers and that thumb might be working just fine. They might have grip strength, but they can't necessarily get the food to their mouth, either because they cognitively can't do it or they physically, their arm isn't working as well as it used to be. So you should be sitting on the side of the person. If they're right-handed, you sit on the right side. If you're left-handed, you sit on their left side, and you take your hand and place it. You allow them to hold on to the utensil, and then you put your hand around over their hand, and you help them as much as they need to get the utensil to their mouth. Some people just need a little bit of help. In that case, you just barely touch it and bring it up, and others will need a lot. And you might be lifting and bringing their mouth or their hand to their mouth completely. But try to allow them to do as much as they can. Putting your opposite hand on the person's shoulder that you're working with to stabilize can be beneficial as well. And again, to make it as natural as possible, kind of consider how you feed yourself, where it comes. It usually comes directly into the center. If you're bringing the spoon at them from the side, their brains aren't going to quite handle it just right. So making sure that you're using your hand to make as natural of a movement as possible can be really helpful. The underhand technique or hand underhand technique is is a situation where the person is either no longer able to use their fingers with the same amount of grasp to hold on to a utensil, or they are no longer able to understand it cognitively to be able to hold on to that. Again, finger foods are a great option, but if utensils are being used and they need this, you can hold on to the utensil yourself, and then they can put their hand on top of yours. So your hand is under their hand. And again, you sit on their dominant side. You use their dominant side to feed them or to help them feed themselves, and you support their shoulder with your other arm. Again, having it still allows them, even though it's a decreased amount of ownership of feeding to do it this way because you're holding the utensil, they still have some ability, their brain still has some input that their hand is coming up and they're naturally able to be able to kind of help you with hopefully the opening of the mouth and being able to understand that they're still participating in the activity. So again, just making sure that that movement is natural and talking them through what you're doing. And then the final technique is direct hand technique, or you are feeding the individual yourself. So this is really, this should be reserved for people who just physically cannot do the feeding task themselves. Either they don't have enough energy to complete the task, they just get too tired out, too worn out, in which case sometimes it's good to let them do the beginning of it, but when they get too tired, then you go and help them feed. Or if cognitively they have no awareness of what they're supposed to be doing, they're not helping in any way, or they have no functional movement because of a stroke or because of a spinal cord injury or something. They have no functional movement of their upper extremities where they can help. Sometimes this is long term and it's used for the rest of their lives. Other times it can be used in a short-term basis until improvements can be made. And then you can go to one of the other techniques. But again, same thing, but especially the more verbal cues, the more you can tell them what you're doing, the better it's going to be for this direct hand feeding because they no longer have any input from their hand and their arm as to what you're doing. So it's really helpful if you can provide those verbal cues as much as possible. So in looking at information for this presentation, I found this study that I thought was really interesting, and so I'm just adding it here. This study compared those three feeding techniques we just talked about, the hand over hand, the underhand, and the direct feeding. And it was found that the time it took to assist someone with feeding was not significantly different based on all three types of feeding techniques. Um, but it was found that the percentage of meal intake was significantly higher for people who had the direct hand techniques. So you're feeding them completely and they're not helping at all, or the underhand technique rather than the overhand technique, which I found really interesting. I would have not guessed that. And further, that over the hand technique, hand over hand technique, seemed to cause more feeding behaviors such as refusing to eat or refusal to open the mouth or spitting out food, which again, I found really, really intriguing because I would have guessed that the more they did for themselves, the more they would take ownership. But something to note through this is that feeding behaviors are commonly associated, like what I just said, as refusing to eat or spitting out. But resisting can also be just communicating their preferences and saying they don't like that. So if somebody, refused peas and the caregiver who was feeding them offered them applesauce, and they were offered that food and they took it, it was still considered um, a refusal or a behavior, but they were able to still eat. So I think that that is just something to remember that if there are some behaviors, giving someone a certain food, especially if you're feeding them directly, um, maybe try a different food or maybe say, well, you don't seem to be liking your peas. Why don't we try the applesauce and see if that gets a better reaction versus just stopping feeding, because that can obviously decrease the amount of food that they intake. So the last thing that I want to kind of go over is the idea of um, the a person as a social being and within their own cultural contexts. So again, if you put on if you wear contacts, you probably put a right eye contact in first and then a left eye contact in first, or vice versa, and it's always been that way. If something happens where you have to put the other contact in first, it can be a little confusing. Sometimes I'm like, oh, I put the wrong one in. Or if again, I've had conversations with my students where I'm like, do you put toothpaste on your toothbrush first, or do you wet the toothbrush first before you put the toothpaste on? And there can be like mm, real conversations about what is right and what is wrong. All of that being said, is that how a person is normally used to their feeding routine can greatly and a dividing from that, moving away from that routine can be really detrimental to individuals. So if you are working as a CNA in a skilled nursing facility or a hospital or any place like that, the routine of your patients might be vastly different than what they're used to at home. They may eat at 4 o'clock in the afternoon at home. They might eat one meal at 3 o'clock in the afternoon and not have a lunch and a dinner. And, as a facility, they're requiring lunch and dinner at noon and 5 or something like that. And that can make a big difference. They might be very introverted people who only like to eat by themselves, and suddenly they are thrust into the situation where they are forced to sit with three other people, and there's lots of distractions and lots of talking. Um, they might like to eat in front of their television at home, and they're not able to do that, or they might never eat in front of their televisions, but it's in a hospital and now they're in bed and the television's on. And so considering that routine, and is there, if someone is a person who is not very adaptable, and we know that as people age they become less adaptable most of the time, so if they've got a very strict routine that they're used to doing every day, and they're not very adaptable, and they're now asked to eat at this weird time in this weird location, unlike anything they've ever done, it can really affect how they're eating or how much food they're taking in. So and what's normal for them culturally. Like, do they have dietary restrictions because of their culture, or do they prefer certain foods because of their culture? Just having a conversation with them, oh, doesn't seem like you're eating a lot. What's going on? And if there is any sort of thing that you can do to advocate for them, then they're going to remember that, and it can be really beneficial. So, kind of in summary of all the slides that I have gone through today, there are lots of things that can cause problems with feeding, that can cause those difficulties. And each person is an individual with different social situations, different cultural situations, with different physical and cognitive impairments. So, each person is different. Lots of things can affect it. But if you notice that they're having a problem, take a step back, look at them for a second, maybe ask them a question. If there's an easy solution, I've mentioned lots of simple tricks here. If that can be a fix and it's done, then that's fabulous. But no matter what you're doing, talk with the person while you're helping them with things. It gives them a sense of ownership to know exactly what's going to be going on as it's happening. So that can be really helpful. And if all else fails, talk to someone in therapy or talk to nursing and see if there is something more that needs to be done for these individuals that we might not be aware of. Because we haven't been working with them with that feeding, and you have. So that is all I have for today. If you have any questions, if anything comes up regarding this or any questions about anything else, you can contact the SLUE Family Center for Healthy and Aging through this email address or phone number. There's a website, or I have my individual email. I'd be happy to answer any questions as well. And I have a few references, but otherwise, thanks for listening and taking the time to be better CNAs for your patients.